Dr. Mirjana Mitrovic from the Clinic of Hematology at the University Clinical Center of Serbia. Is that correct? Have I got it right?
Yes.
Who has a major interest in benign hematology. I know you've published over 100 papers and you have a big interest in ITP also, and you're going to talk to us about ITP in pregnancy. Thank you so much.
Thank you for the introduction. Thank you for inviting me. It is so hard to me to speak after Professor Kuter, but I will try and give my best for this. My topic is pregnancy and ITP, and I will try to raise some very important questions and to respond on some of them. We will start with diagnosis of thrombocytopenia and ITP during the pregnancy. As we all know, thrombocytopenia is not rare during the pregnancy, and some 12% of the pregnant people can develop thrombocytopenia. As you can see, we can separate all causes of thrombocytopenia in two big groups: non-pregnancy specific, including immune thrombocytopenia, or these causes are rare during the pregnancy. And of course, we have a big group of pregnancy specific causes, and most important and most frequent one is gestational thrombocytopenia, very mild, benign condition, not need for therapy, and platelet count rise and normalize very quickly after delivery. When we speak about differential diagnosis of thrombocytopenia in general population, it's very complicated. During the pregnancy is more complicated because we all know that we have this group of conditions associated with pregnancy, and we must think about them. Cornerstones of diagnosis of thrombocytopenia during the pregnancy are, of course, good personal and family history, good physical examination, and peripheral blood smears. We always think about, in cases of isolated thrombocytopenia, about ITP and GT, but firstly, we must think and exclude all alternative options. We must ask about medication and supplement because drug-induced thrombocytopenia is not so rare. We must think about nutritional deficiency, which can cause thrombocytopenia. Patients can have some pre-existing condition which can worsening during the pregnancy, such as ITP, von Willebrand type 2B, or some congenital disorder. Of course, patients can develop new conditions during the pregnancy, and we must ask about symptoms and search for signs for some autoimmune or some infection diseases. If the thrombocytopenia is with some type of hemolytic anemia during the pregnancy, we must think about preeclampsia, HELLP syndrome, and TTP. However, if we exclude all these alternative options, we will stay only with two differential diagnosis possibility, GT and ITP. And we can make diagnosis nowadays only based on clinical symptoms and signs. Let's say that we must think about timing of thrombocytopenia. If the thrombocytopenia develops during the first trimester, this is probably ITP. If the thrombocytopenia developed during the third or late second trimester, this is probably GT. Secondly, we must think about platelet count. If the platelet count is low, less than 80, or let's say for sure less than 60, this is ITP. If the platelet count is stable, higher than 100, this is probably GT. However, we have some window between 80 and 100 where we're not sure about diagnosis. And I must say that 1/3 of all patients who were diagnosed with GT will be reclassified during the pregnancy, most frequently because dropping in platelet count and need for therapy. Of course, some of these reclassified patients have very prolonged thrombocytopenia after delivery as a cause of reclassification. And for that, we should think about some additional laboratory tests that can help us to make a diagnosis. We have two candidates, but however, they are not proposed by any guidelines. The first one are antiplatelet antibodies. Nowadays, tests are very sensitive and very specific. However, the tests are not standardized, and we don't use it in everyday practice. The second is thrombopoietin level. During the pregnancy, TPO levels in ITP patients are very high in comparison to non-pregnant ITP patients, and especially in comparison to patients with gestational thrombocytopenia. However, nowadays we don't have a validated cutoff level to make a differential diagnosis between these conditions. If you treat a patient with ITP, you for sure know that during the pregnancy or when they planning a pregnancy, they will always ask, how will my pregnancy impact my RTP? And is there any risk of worsening this disorder? As you can see on this dark blue line, during the pregnancy, normal pregnancy platelet count will fall down and the minimal level will be around delivery. And on the right side, you will see that, however, the platelet count less than 80, especially less than 60, is very rare in normal, non-uncomplicated pregnancies. However, during complicated pregnancies, light blue line, you will see the decrease of the platelet count and then sharp decrease in the third trimester with thrombocytopenia less than 80 and less than 60 will be more frequent. And the end, red line, this is platelet count of patients with pre-existing condition with thrombocytopenia like ITP. The platelet count will be lower, and you can see again sharp decrease, and half of our ITP patient pre-existing to pregnancy will have a platelet count less than 18 during the pregnancy. What is the reason for this decrease during the pregnancy? We all know some classical explanation like dilution, increase in spleen size, or placenta consumptions. But however, new data show that in bone marrow of pregnant ITP patients, there is frequent megakaryocyte hypoplasia, not typical for ITP without pregnancy. And this can be immune mediated too. However, during the pregnancy, we should not forget reasons related to pregnancy, like some hormones or cytokines, and very high estradiol level that we reach at the end of the pregnancy can cause megakaryocyte apoptosis and reduce proplatelet formation. Inhibin A level in some cancers can cause bone marrow hypoplasia too, and inhibin A level is very high at the end of the pregnancy. According to different papers, the risk of ITP worsening during pregnancy is 30%. And in this very interesting French study, they compare number of episodes of worsening in pregnant ITP patient with a non-pregnant ITP patient in the same period of time. Interestingly, the first ITP worsening was not more frequent in pregnant group. However, recurrence of severe thrombocytopenia and treatment modification were more frequent. Authors think that this is probably due to very strict and frequent monitoring of the patients during the pregnancy. However, we should not forget the impact of pregnancy on bone marrow and disorder, and recurrence of bleeding events and severe bleeding events were not more frequent in pregnant group. However, this is probably due to excellent therapy that patient had in pregnant group. The biggest fear of patients with ITP, and according to my experience, the biggest fear of obstetrician is bleeding, especially if we know that platelet count less than 50 is the big risk factor to severe bleeding, irrespective of thrombocytopenia etiology. Gonzalez-Porras' big meta-analysis showed that maternal bleeding during the pregnancy is reported in 2 to 45% of patients with ITP. Most bleeding episodes were minor, like skin bleeding and nose bleeding. Postpartum hemorrhage incidence ranging between 0 and 20%. In this meta-analysis and systematic review, there were no maternal deaths in any of 15 studies, and they concluded that primary ITP in pregnant women is rarely associated with poor outcome. However, maternal bleeding and especially postpartum hemorrhage were more frequent in the ITP patients. And because of that, it's very important to try to identify a patient with high risk of postpartum hemorrhage. Nowadays, we know a lot of different important antepartum and intrapartum risk factors. Let's say for antepartum, they are related to the patients such as obesity, coagulation disorder, advanced age, or previous history of PPH. Intrapartum risk factors are some interventions such as episiotomy, utilization of forceps or vacuum extractor, any genital tract lacerations, and placenta disorders. We can use these predictive factors in our ITP patient, but maybe it's better to use validated study, monitor study, which is designed to predict risk for the bleeding in the moment of the delivery. As you can see, it is interesting that this monitor score combine risk factors related to the general population, like placenta abnormalities, previous uterine surgery, and similar factors, with some ITP-related factors like bleeding score, platelet transfusion, platelet count, and similar things. If the monitor score is very low, like 0, risk for bleeding is very, very low. If the score is maximal, 17, risk for bleeding is very high, and almost all patients with score high like this will bleed. Why is that important? When we know that patient is in a big risk, we can schedule the time of the delivery, treat a patient to achieve safe platelet count, and most important, organize experienced team to go with a complicated delivery like this. Oh, I have some problem, okay. And second question of pregnant patient will be, is there any risk for my baby? As we all know, maternal IgG antibodies can pass through placenta and target neonatal platelet membrane glycoproteins, causing thrombocytopenia. According to systematic reviews, the incidence of neonatal immune thrombocytopenia is somewhere between 6 and 23%. And typically, the lowest platelet count was achieved during the first 7 days, often on days 2 to 4, and after that, platelet counts start to rise and normalize. During this period of thrombocytopenia, neonates can have some bleeding. Usually, this is non-severe bleeding, and weight event rate for non-severe bleeding is 0.075. However, in this big meta-analysis with near to 900 patients, 5 cases of intracranial hemorrhage was registered, and 2 cases on severe bleeding or other localization, with incidence of neonatal mortality near to 1%. Intracranial hemorrhage was associated with vaginal delivery and severe thrombocytopenia in infants. And because of this very high mortality, we should predict neonatal thrombocytopenia development, but we are struggling to identify a risk factor during all these years. Some factors were predictive in all studies. One of them, prior history of neonatal thrombocytopenia. If mother had a neonate with neonatal thrombocytopenia, risk for next pregnancy is 14 times higher. In the majority of the studies, antiplatelet antibody and splenectomy were predictive too. Conflicted results was about low maternal platelet count, and we nowadays know that immunosuppressive treatment do not have any impact of neonatal thrombocytopenia development. There are some new predictive factors like low platelet to lymphocyte ratio in second and third trimester. I want to say that it's very important to think about neonatal thrombocytopenia all the time in all ITP pregnant patients, especially in patients with normal platelet count after splenectomy. And if the low platelet count is prolonged beyond days 5 to 7, we should discuss stopping the breastfeeding, because EGA antiplatelet antibodies can pass in milk and cause neonatal thrombocytopenia. In the end, we should discuss safe platelet count and therapy, of course. During the pregnancy, we must have a very frequent monitoring of the patient during the first parts of the pregnancy, 1 monthly, to check bleeding symptoms and complete blood count. indication for the treatment are bleeding and platelet count less than 20 to 30. How we approach to the delivery, we should raise the frequency of the monitoring, and after the week 36, we should have a visit every week. The safe platelet count, according to nowadays guidelines for vaginal and cesarean section, are higher than 50, and for epidural and spinal anesthesia higher than 70. However, these data are or this number are a little bit arbitrary because they are not pulled from studies with pregnant ITP patient. In majority of the cases, they are not pulled from studies with pregnant people at all, but from general population. And we all know that pregnancy is procoagulant state and that probably these numbers can be lower for pregnant people. However, nowadays, this is the numbers. And we are always thinking about quantitative side. We are always thinking about platelet count values. We don't think about qualitative side of this disorder and impact of antiplatelet antibody-induced thrombocytopenia for bleeding. We don't have any data for that. During the pregnancy, some patients will need some type of the therapy. In the first line, we can use corticosteroids and IVIG. And when we choose a therapy for the pregnant patient, we should think about efficacy, consideration for the mother, risk to fetus, and of course, effects on lactation. If we speak about efficacy, as you can see, efficacy is much smaller during the pregnancy. And if we go to prednisone, we can say the considerations for mother are the same like in general population. These drugs do not cross placenta and the risk for fetus are very small. On the other side, dexamethasone is crossing placenta and can induce placenta abruption and premature rupture of fetal membranes. But more interesting are some sort of postnatal toxicities, which can lead to neuropsychological impairments, liver disease, and behavioral disorders. And because of this, all guidelines and all key opinion leaders advise to use prednisone over dexamethasone during pregnancy. IVIG you can use in both dose regimens. There are not some special consideration for mother and fetus. However, when you applied IVIG, you must think that in some patients, response will be very short, 3 to 5 days, and that in all patients you must repeat infusion, and with every repetition, the efficacy will be decreased, and of course the drug is very expensive. For me, there are two big questions in field of first-line therapy. First is dosing of corticosteroids, and I will show you two Chinese papers. In the first one, they use standard 1 milligram per kilogram dose and achieved 35% of response in pregnant ITP patients. However, the incidence of pregnancy-induced hypertension was very high. In second one, they reduced the dose on the half or quarter of milligram. This picture is for the lowest dose, quarter of milligram. The picture for half of the milligram is very similar. As you can see, they achieved a response in some 30% of the patients. However, some of them, of course, lost response during the follow-up and were introduced to full dose of 1 milligram and respond to it. When they use this increase in dosing in no-response patient, response was very, very unusual, and they advise not to use this strategy for treat these patients. Author, in the end, concluded that lower dose prednisone is not less effective than high dose prednisone and reduced the incidence of maternal complication. And second question is when to use cortico or IVIG or combination therapy. Authors of this study use all three options and show that in combination therapy, the number of days that patient was on corticosteroids was much smaller. And in combination therapy, the rise of platelet count was much quicker than in comparison to IVIG's solo or only prednisone group. However, maternal response, platelet count at delivery, and frequency of hemorrhage was the same were the same in all groups. Probably this study showed that we should use IVIG corticosteroids combination only in urgent situation like bleeding, very low platelet count, or when we need some intervention. And in the end, some of the patients we will need second-line therapy, and second-line therapy is always complicated in ITP. However, it's more complicated in pregnant patients because we have some teratogenic drugs like MMF, fosamatinib, danazol, dapsone, cyclophosphamide. We can use rituximab. Consideration for the mother are the same like in non-pregnant population, but after the 16 weeks of gestation, rituximab can cross placenta and cause neonatal B lymphocytopenia. Hypogammaglobulinemia is very rare, especially if the mother has normal IgG levels. We should think in the group of the babies that they can develop hypogammaglobulinemia after 3 to 4 months after delivery. And if we use rituximab during the third trimester, we should skip the live vaccines until the 6 months of age. In conclusion, we can use rituximab if the indications are clear. However, patients are encouraged to avoid pregnancy 6 to 4 months after rituximab usage. When we speak about azathioprine and cyclosporine, both of them are slow drug, meaning that they need a lot of days to achieve some response. Cyclosporine is related to preeclampsia, and we don't use it oftenly during the pregnancy. There are some side effects for azathioprine. However, the drug is recommended in majority of the guidance for pregnant patient with ITP. In the end, we perform splenectomy very rarely nowadays in general ITP patient population. However, I can imagine that in some places in the world, some patients need splenectomy. It should be performed during the second trimester only. And at the end, we will discuss thrombopoietic agents during the pregnancy. We all know the mechanism of action: increased megakaryocyte maturation and platelet formation through activation of the TPO receptor. This is very interesting mechanism because it looks like very effective in the pregnancy of ITP patient when the bone marrow is with megakaryocyte hypoplasia. Nowadays, we are using 2 groups of of thrombopoietic agents: recombinant thrombopoietin and TPO receptor agonists. Recombinant human thrombopoietin does not cross the placenta and has no teratogenic effects. Liu et al. Study of pregnant ITP patients showed that patients who were treated with recombinant human thrombopoietin had higher platelet count, lower bleeding, platelet transfusion rate before delivery, as well as longer gestational weeks. However, the rate of C-section and postpartum hemorrhage were the same. Especially important, maternal and fetal neonatal complications were similar. Maybe we can say that this drug is safe during the pregnancy. However, the drug is registered only in China. If we speak about romiplastin, there is a lot of data about romiplastin usage during the pregnancy. I will show only data from Amgen pregnancy survival program, which include 186 women who were exposed to romiplastin. As you can see, 40% of them during the first trimester, 12% during the second, and 24% during the third trimester. Efficacy was preserved. And when we speak about pregnancy outcome, half of the patients had normal pregnancy, 37 had some ITP-related abnormal pregnancy. This is expected because patients who were treated with romiplastin are very refractory ITP patients, and 60% of them had a non-ITP-related abnormal pregnancy, meaning 11 patients with miscarriages and 4 patients experienced VTE. And this is very important data because we all know that ITP is procoagulant condition and pregnancy is procoagulant condition, and will probably think about the possibility to develop thrombosis if you applied TPO agonist. Of course, drug which can rise the risk of thrombosis. Of course, this is not clear data. We need prospective study to conclude something about this. In the end, about birth outcomes, 65% of births were normal, and 70% have spontaneous abortion, ectopic and molar pregnancies, and stillbirth, and 70% have some other complication like congenital anomalies. For L-thrombopag, amount of data is smaller, only 21 pregnancy, and response was achieved in 80% of the patients. Response was good. However, adverse events, I'm not sure that there is only 4 adverse events, and I will introduce 2 of them: intrauterine growth restriction, preeclampsia, and placenta infarctions, and 2 cases with neonatal thrombocytosis. We don't have any data for avatrombopag. And the end of the part with TPO agonists, we can say that we nowadays have a lot of data about usage of these drugs during the pregnancy, and reports of placenta infarction and thrombosis are concerning. However, it looks like that we can use these drugs safely, especially in the 3rd trimester and maybe during the 2nd trimester too. In the end, mode of delivery, according to mentioned meta-analysis with systematic review, the proportion of C-section in the group of the ITP patient exceed 40%. This is a very large and big number. Indication mainly were obstetrical. However, a big chunk of these patients had ITP-related indications, meaning that in some cases there were very high risk for neonatal thrombocytopenia. And the second group was mothers with very low platelet count, and the doctors thought that it is safer to perform C-section. However, cesarean section are associated with greater blood loss than vaginal delivery, and we can say that induction vaginal delivery is typical preferred to cesarean section, and surgical delivery should be based only on obstetric indications. For the end, as we all know, we are not so good, like ITP treating doctors, we are not so good in adherence to guidelines, especially in the field of corticosteroid usage. And I want to introduce the data about pregnancy, which are not so good, let's say. 36% of of doctors will treat moderate thrombocytopenia just to be on safe side, and 38% of the doctors will apply therapy in the pregnant patient with platelet count higher than 70 to achieve safe platelet count, because they think that safe is bigger than 100. And of course, there is just a possibility to achieve some adverse events. In conclusion, ITP is not contraindication for the pregnancy. Pregnancy in ITP patient is team game. Before the pregnancy and during the pregnancy, in the team we must include gynecologist, and before the delivery, neonatologist and anesthesiologist too. And we should be proactive rather than reactive in management. Thank you for your attention. Greetings from Belgrade.
Thank you so much. Thank you. Okay, we've got time for a couple of questions. Dr. Gonzalez-Lopez has a question. Could you hang on 1 second? Okay, Thomas.
Hello, Mirjana. Excellent talk. Yeah, I would like to know your opinion about a topic that is a real controversy. Do you think that we can consider completely safe using TPORAs in the first 3 months of the pregnancy? Because you know, we have the paper from the Chinese group that published, I don't know, more than 300 people, 300 women who took RH TPO with success, but there are a controversy because during the first 3 months of of the pregnancy, potentially TPRAs could not be safe. So what's your opinion regarding that?
I'm not sure. Because of that, I said on the beginning that I will write some question that we should discuss. 40% of the patient in this Amgen survival registry was used the drug during the first 3 months, and frequency of some congenital anomalies were not more frequent than in general population. But in this moment, I'm not sure that we have enough data to support usage of TPO-RA during the first 3 months. I will try to skip it on if I can.
If you were an ITP pregnancy woman, you will take the pill or not?
Okay. It depends on bleeding, on symptoms.
She has been mom recently.
Yeah, my baby is 1 month old. I will skip it. I will try to skip it. But we recently had a patient with lung bleeding. We applied romiplastin during the first trimester. The babies were okay. But if there is any significant bleeding, I will not apply it just for the platelet count.
Okay. What about the second trimester, Thomas? Would you use it in the second trimester? Perhaps. Would anyone use it second trimester? Any of you guys? Yes? No? Yes, no?
Obviously,
yes, no.
Obviously,
would you use it in the second trimester?
If I must, yes.
He's a yes.
Yeah.
Who else? Yes, another yes.
Yes.
A yes, that's 3 yeses from about 3 clinicians I've asked. Would I use it? I don't know. No, probably
I
no.
prefer to use it in the third trimester.
Yeah, of course, but that wasn't the question. It was the second.
I know that it wasn't the question.
Yeah, these are hot topics. And the steroids as well. I've never used dexamethasone in pregnancy. Have you? Dexamethasone? What dose do you use in pregnancy of dexamethasone, Mirjana? What dose do you use?
I have tried not to use dexamethasone during the pregnancy. I know that it's recommended to reduce dose to 20 milligrams, even for a lung maturation in the last part of the pregnancy. I guess that if I have a patient who needs a dexamethasone, I'm not sure why, I will reduce the dose.
Okay. Walid, you want to ask something?
Yeah, short question. What is your tip of choice? I mean, eltrombopag or romiplastin if you use, and what do you do regarding breastfeeding on TPO? That's an issue we often get confronted with, or a problem with probably after delivery, those who need to continue and they want to breastfeed.
Did you get that? Did you get the question?
Yeah. I'm just thinking about it. I preferred to use romiplastin because amount of data is much bigger. In only cases that I had, 3 or 4 cases, we use romiplastin. However, after delivery, the platelet count were stable and we didn't treat a patient. I'm not sure about breastfeeding, but if you must treat a patient, we will continue then.
Yeah, some of the babies, they get high platelet count. So yeah. And I've had a couple of cases where the mothers insisted on breastfeeding. At the end, after 3 months, they have to tell them, you have to stop. I mean, the platelet count really high. And we don't have that experience, I mean, with high platelet counts, the infants, how to deal with. So one should follow up with blood tests.
So, sorry, with romiplastin, how much of it gets into the breast milk? Sorry, how much? Does romiplastin get into the breast milk? How does it get into the breast milk? Does it?
I think it happens.
Mirjana, does romiplastin, how much ends up in the breast milk from the mother's dose?
Low concentration, but in animal studies, romiplastin induce thrombocytosis, and probably the low concentration can cause thrombocytosis too in the babies.
I mean, how much it gets into the breast, this is one question. The other, how come, I mean, what is the mechanism? Because it's given subcutaneously. How come when the infant ingested it, I mean, orally, it increases the platelet. I've never understood it, but what happens? I don't know.
Yeah, it doesn't make sense. Doesn't make sense.
And is this, in your experience, platelet count rise after the delivery? It was high immediately after.
I mean, I've had.
It was high on the delivery, or rising.
I have had a couple of cases, and yeah, after delivery. I mean, the first week or so when we control or check the blood.
And stay high during the 3 months?
Yeah, one of them stayed high until 3 months, and then we had to say, I mean, stop, we don't have more. I don't have more experience. I don't have experience with this, but I've read it, I mean, here and there, that it increases the platelet counts, the baby.
Okay, I think at this point we're going to have to stop, Mirjana. Thank you very much for a really nice overview of ITP and pregnancy. Much appreciated. Thank you for joining us.
Thank you. Thank you.